All right, so it gives me great pleasure once again to introduce Guy Worley, a consultant colorectal surgeon at the Royal London Hospital, who has been a great supporter of Red Lion Group in the past, in particular when he was a locum and a research registrar at St Mark's, where he learnt a great deal of his expertise from the eminent surgeons and professionals that we know and love at St Mark's. He's continued his interest in colorectal surgery and, in particular, Crohn's and fistulas associated with Crohn's. But from our point of view, he's also about to restart pouch surgery at the Royal London, which is really great news. He's going to be talking about alternatives to pouch surgery, alternatives, techniques, and trends, which will be absolutely fascinating for us. And he's still in his surgical gear because he's still at the hospital. So I'm gonna pass you over straight away because you don't want to listen to me and you want to get home. So welcome, Guy. Really great to have you back, and thank you for taking up your Tuesday evening to speak with us.
That is a very kind introduction. Thank you very much. And that was quite the icebreaker to a meeting as well before that. Thank you very much. Um, so so we go back nearly 10 years now. It was 2015 that I was first introduced to the organization as a research fellow at St. Mark's. And firstly, just of course to say what an accolade, for you guys that it's grown so much and what an amazing resource this is for people with quite, niche health uh, problems and options and interests and support for the decision making. I was just saying that I do regularly utilize the Red Line group as a point of reliable information for patients that I see in clinic on a weekly basis. So it is reciprocal. It's I'm very grateful that you're continuing to thrive. So I wanted to partly present some of the work that I've firsthand done in my research time at St Mark's, because that was with the support of the Red Lion Group in for much of it, but also try and contextualize some more general things about current trends and alternatives in for ilioanal pouch surgery. So, looking back to the history of why the ilioanal pouch was created, and this is a sort of presentation in line with John Nichols's sort of talks, that colectomy, removing the colon, was established as a definitive management option for patients with colitis as far back as the 1950s, before steroids were around. Firstly, as well, I am aware that there are two broad cohorts of people who tend to come to having an ilioanal pouch, those with polyposis syndromes as well, of which many will be listening. But sorry that it is sort of premised mostly around colitis. So the problem being, though, that when you're living with an ileostomy in the sort of mid 20th century, that's a real problem. So there was a real push for the second half of the 1900s to trying to develop options for what we call restorative surgery, to do away with having a permanent ileostomy, and through various different sort of developments that culminated in the development of the ilioanal pouch, roughly as we know it today, in 1978, and that was Sir Alan Guy Parkes, who was the president of the Royal College at the time, and the pouch was developed at St Mark's and the Royal London. That's where they were surgeons, which is now where I currently work. So that's a nice sort of circular thing. And then the surgeon that you may well know, having presented at the Red Lion Group, John Nichols, down on the right hand side. And this was that seminal publication. So the landscape has very much changed, though, in that there was such a big push for restorative surgery, being able to do away with that permanent ileostomy, because stoma devices around that time in history were so significantly different to what they are today. And I'd like to think that there is less stigma and there's a sort of better publicity around having an ostomy these days. So a pouch, what is a pouch? Just to clarify, it is where the end of the small bowel, the ileostomy that is created when the colon and the rectum are removed, is used to create a reservoir. So you fold it on itself, making that J shape that we often refer to as a J pouch. which is then joined down to the anal canal, leaving a little bit of the rectal tissue remaining because that's an important area of the rectum that's very sensitive and it helps to contribute towards a sort of continence mechanism. So the idea is that then creates a reservoir that does the job of the rectum that used to be there, and that when that is healthy and functioning well, standard kind of pouch function is going to the toilet about 7 times a day, maybe once overnight. A certain proportion of people will still use Imodium or loperamide to slow things down, and hopefully enjoying relatively good health without having a stoma going to the toilet via the bottom. So the background is that inflammatory bowel disease is increasing in prevalence internationally, probably as Western culture and diet spreads around the globe. But there remains an approximately 1 in 5, maybe a 1 in 3 chance of needing to come to an operation for ulcerative colitis. So that sort of need for surgery remains. And then the algorithm after you've had your bowel removed can be a little bit complicated in terms of you can, of course, just stick with your end ileostomy with or without then deciding to remove the rectum at a later date for various reasons. But then to go down the path of wanting to do away with the permanent ileostomy, there are several different options. So you go from colectomy through to sort of restorative options, and then the potential complications of those kind of options. And that was the sort of rough trend of thought of my thesis, which I won't bore you with all the scientific detail of, but it's just that the presentation is going to roughly follow that kind of pattern, working through that algorithm. So Professor Omar Faiz, who's one of the St. Mark's pouch surgeons, and I wrote an editorial piece about the fact that the medical landscape is changing so rapidly and that there are always different medical and new medical options brought to market. Has there been a meaningful change in the rate of patients going to surgery for colitis with time? Has the colectomy rate changed with time, or is it just pushing things a little bit further down the road? And in some cases, being salvaged with medical therapy away from having an operation, but not always to the improvement in quality of life. So we undertook a research study using nationwide data to see whether that was the case or not. This included nearly 40,000 patients and showed that we sort of selected people who'd had to be hospitalized with nasty colitis, with what we call acute severe colitis. And that within the sort of 1 to 2 year period, having had that inpatient episode, about 1 in 5 people, maybe even as high as 1 in 4 people, were coming to needing an operation anyway at a later date. And that actually the operations for ulcerative colitis were only reducing slowly over time after the introduction of the biologic medications, most notably infliximab. And the elective, the planned surgery looked like it was decreasing, but the proportion of patients having an emergency operation was not decreasing, which was interesting. So again, there's potentially something in this argument that for people that have nasty disease and it maybe looks like an operation is inevitable, will the medications help in the longer term, or do they simply temporize things? And it's of course a very nuanced conversation, but that's the essence of it. And this graph shows the blue lines, which is the sort of decreasing operation rate very slowly versus the massive increase in biologic medication prescribing. And so moving down towards the options then for restorative surgery, which is what, of course, we're most interested in. So this slide is an homage to Professor Sue Clark. So you may well also be very familiar with Sue Clark. She's one of the hugely experienced inflammatory bowel disease, polyposis, and specifically pouch surgeons at St. Mark's. But even more specifically, it deals and has spoken internationally on pouch complications, to the point whereby things are really bad and you're considering removing the pouch completely. And she uses the analogy that making the change from sticking with an ileostomy to considering a pouch is a little bit like the difference between owning a Ford Fiesta versus a classic car, in that your pouch is your classic car, which when it's running perfectly is an absolute wonder and a joy. But you've got to anticipate that there might be plenty of times where you need to tinker with it in the garage, and sometimes it might break down completely. please don't take that as being flippant. I know I'm talking about people's health, but it's an analogy that she uses, and I think it's a good contextualizer for thinking about the sort of decision burden of whether to go ahead to consider an ilioanal pouch or not. And so these are broadly speaking the options. So if after your colectomy you don't want to stick with your ileostomy on the left hand side, then the most obvious option, particularly in the UK and probably for much of North America, is to go with having an ilioanal pouch, where again the small bowel is created into a reservoir and joined down to the bottom. Another option is to consider having an ileorectal anastomosis. So where the first operation leaves a small percentage of the large bowel remaining, normally the rectum and a little bit of the last part of the colon, the sigmoid colon. If that area is not too badly diseased and not too inflamed, then there's a potential option to join the small bowel onto the top of the rectum or the sigmoid colon, which avoids the need to go down into the pelvis to remove that part. And there are some pluses and benefits to that. I'm going to review that in a bit more detail on the subsequent slides. And then there are the continent ileostomy options. So these are the options where it's still an ileostomy coming out to the skin, coming out to the abdominal wall. But rather than it being just a free stream of effluent that comes into the bag all the time, they are, in inverted commas, continent. So the idea being that they require a catheter, often a Medina catheter, slipped into the opening on the surface of your tummy to drain the reservoir beneath the skin, beneath the abdominal wall. And then, and I'm actually only aware of one of these called the TIES device, TIES, which you might have come across at the bottom of the screen there, is another continence type device to go around an ileostomy, but is a little bit rarer. So one of the research projects that we undertook in regard to this question about the pouch versus the ileorectal anastomosis was a comparative nationwide study, again, between ourselves and Swedish colleagues, because there has been a sort of premise over the last few years that the ileorectal anastomosis has sort of come back into fashion in Sweden and is potentially utilized more commonly than an ilioanal pouch and is offered to patients there, whereas it's much rarer over here. So we compared the data between the two countries, and my main counterpart here was a associate professor of surgery now in Stockholm, called Caroline Nordenvall, whose picture is in the top right of the screen. So it was nearly 100,000 patients this time that we used between the two countries, amounting to over 10,000 colectomies. And what we found was that in England, and I say England specifically because that's where the data come from, it wasn't the entire of the UK, only half of the patients that had a colectomy for their ulcerative colitis, only a third, in fact, ended up going on to have restorative surgery, whereas it was a half of the patients in Sweden. So still not great numbers, but more patients were proportionally being offered restorative surgery and doing away with their permanent stomas than in England, presumably the UK. In England, 90% of the patients that had restorative surgery had an ileoanal pouch, whereas in Sweden, the majority of patients for their first procedure was an ileorectal anastomosis at 60%. So is there something in this being an option that makes the difference between more people being offered to do away with their stomas, and are patients in either country being done a disservice in that regard? So that's that graph that shows the difference between the number of people that opt for restorative surgery and do away with their ileostomy with time up to about 10 years after their colectomy. And we also, as a secondary kind of outcome, noticed that it makes a real difference where you have your colectomy, where you have your first operation, as to the chance of you then going on or being offered to have restorative surgery afterwards, which is a talking point maybe for a bit later on in this presentation. I won't run through this in detail, but for the people that are watching post hoc, then it might be a nice time to pause just to be able to look at a table of some of the differences, the positives and negatives between having a permanent ileostomy versus trying to have a pouch or an ileorectal anastomosis. And that research was included in the national guidelines for inflammatory bowel disease surgery. So, that's the work of St. Mark's, endorsed by the Red Lion Group, that's making a difference on a national basis. And we then developed a prospective study between both countries, trying to measure what happens to people as they go forward after their colectomy. So then, for the sake of thoroughness, but these operations are quite a lot rarer, just to review the sort of continent ileostomy options. So this is what is referred to as a cock pouch, K-O-C-K, invented by Niels Koch, who was a Finnish surgeon who mostly worked in Sweden, died in 2011, but he was responsible for this sort of quite complex folding the bowel into a shape that was one of the sort of precursors to being able to make the pouch as per Parks and Nichols. And you can see there that it's quite a complicated thing. And of course, this isn't just fabric. This isn't just, any old material. Bowel is attached to a blood supply. There are surfaces that will and won't stick to each other. It has to stay in a certain place. It has to be stitched and not leak. So it might look that it's complicated enough sort of making these kind of shapes, but actually when you're considering that these are tubes with their own blood supply in different tissues, it is actually an enormously complicated thing to get your head around and then achieve on table. And it's a common rule of most things in life, but particularly surgery, in that simple is best. And if anything that's created that's overcomplicated, then it's potentially doomed to failure. And the complication rate with these different types of continent stomas are very high. But again, similar sort of analogy, for those people in whom they do them very well, they're very much loved and cherished. But there's an even higher expectation here that you might have to do some tinkering or there be a problem. But the flip side is that the number of surgeons and institutions that are experienced in looking after continent ileostomies are rare. And so that's a real consideration. And the majority of surgeons would be fairly reticent to offer this kind of thing unless there's a really good reason. And then there is even less data available about these kind of things. And there is a certain amount of sort of surgical principles that having a foreign body around bowel, in terms of the health of the bowel, but also the potential for infection in a contaminated environment, is a bit of a no. But that's not, that's for anybody that is interested in this kind of thing. Please search out the literature themselves. But it's much rarer to be offered a sort of a non-tissue device. So as we move down then through the algorithm, to think about, if you're going to have a pouch, then getting it spot on and working to the best that it can and avoiding complications is absolutely paramount. And when counseling people to consider pouch surgery, if that's what they would like, I quote broadly that a third of people will do very well with that expected best function and maybe not have to have any further interaction or very much interaction with their hospitals. A third of people will have problems, mostly in the case of ulcerative colitis pouches, with pouchitis. About half of people will suffer from pouchitis, but there are several and varied other potential problems that will need some sort of tinkering in the garage, to go back to the car analogy. But relatively minor problems, maybe courses of antibiotics, maybe another second operation for a fistula, for example, that then does heal. That will require a bit of contact, but on the whole be tolerated and do well. But then a third of people will really suffer with poor function from their pouch for whatever reason. And we quote that around 1 in 10 people within 10 years of having a pouch will have had it so bad that they'll want to consider having a stoma again. And that then is normally a permanent stoma. And unfortunately, we would always sort of counsel people that the function that you would expect from that stoma, that ileostomy, may never be quite as good as the one that you had originally after your colectomy, because it's a little bit further up the bowel. It's a little bit shorter to the stomach. And sometimes it can be formed in a way that's not quite as straightforward as an end ileostomy that they had before as well. So with that in mind, trying to get it right at the time of surgery is extremely important. I must also say it is not just the surgeon and the surgery that makes a difference to how the pouch goes. Ileoanal pouch allied services and support, specifically pouch nurses, are the people that keep you running with time, are able to troubleshoot and be a point of contact. So that is enormously important. But of course, as a surgeon coming at a research project, we were kind of focusing on what's important. And we think the join that you make between the pouch and the and what's left of the anal canal and the rectal cuff is pretty much the most important part of the procedure. And it's something that has been a little bit refined in recent years, and I just wanted to contextualize that for you. So there has been what I was showing on this previous page. If you look to the bottom left of the screen, there's a few technicalities about how you make that join, and we use stapling devices, and what we call a linear stapler, which is a sort of side to side. It goes across bowel and cuts and staples at the same time. And then when you do that, you end up with what we call dog ears. You see the bottom leftmost picture, whereby the lower part of the bowel, the one that's going down to the anal sphincters, has that kind of horizontal staple line with the bits poking out either side, and they inherently probably suffer from a bit of a lack of blood supply and are a weak point. And it's theorized that is a weak point then for the joint. And so over recent years, there's been a real movement to try and work out how we can eliminate that and make a purely circular stapled joint. And Professor Fays and some of the rest of the team at St. Mark's, Danilo Miskovich, one of the other consultant surgeons, who's a highly experienced robotic surgeon, have been utilizing the robotic platform for ileoanal pouch surgery to try and utilize that to its best effect to make a new sort of type of anastomosis, a purely circular anastomosis. Now that video is not playing for me. Is it playing for anybody else?
Yeah.
So I'll take you to the different points. So this is, I thought, also would be of interest for people that haven't seen robotic surgery. So robotic surgery is a misnomer. It should really be called surgery by wire, because there is no autonomy to the robot. There's nothing to do with it that operates by itself. It simply means that the surgeon is sat at a console in the same room, remotely operating robotic arms to do what's necessary. But the advantage being that those instruments are articulated and give a more sort of natural wrist-like ability, as opposed to the old straight keyhole laparoscopic instruments that we have. So it has been a sort of a paradigm shift for surgery around the globe, but also utilized for colorectal surgery. So this is going down in the pelvis and removing what's left of the rectum, going all the way down to the pelvic floor, which most people are familiar with the term. That's the muscular sling at the bottom of the pelvis that keeps all the organs up, and that's where the beginning of the sphincter complex comes. So this is where the rectum is divided. So it's opened up, having washed everything and made it clean inside. And so rather than stapling across, it's opened up in an open tube. As the rectum is then removed, the pouch is then made, and this is what that looks like. So bringing the small bowel outside the tummy and folding that small bowel into a reservoir with that anvil of the stapling device tied in, to then introduce that back down into the pelvis above where the anal sphincters come. And the robot allows you to quite reliably stitch 2 purse string sutures down in quite a narrow environment to be able to very accurately get just the right height above the anal sphincters to then make the join as precisely as possible. So that's Professor Omar Fays using the gun and the 2 bits of tissue that come away with that, one from each side, which are really good chunky, healthy, reliable donuts of tissue, sort of signifying that it's a really good, robust anastomosis. And there's some sort of pan-European research going on as to trying to really refine everything we do at the time of pouch surgery to make sure that sort of it's as you know, you get it right first time and off to the best start possible. So with the group, we published some further papers about how best to manage pouch complications, and St. Mark's has a real legacy about publishing on this kind of topic and being a go-to resource to try and optimize pouch function as best as possible. And some of my work was looking at trying to really drill down on how to monitor people in the post-operative period, and we noticed that there's probably an element of diagnosing leaks from the pouch, the problems with the join that is made if it goes wrong, if it doesn't heal perfectly, and is there anything that we can do to optimize that? So we did some MRI work with the support of the Red Lion group, and I recruited participants from the Red Lion group who were kind enough to come and offer their time, and this was because they were people who were identified as having well functioning pouches. So what we were mostly relying on previously are these two-dimensional X-rays. So this is called fluoroscopy. So when you're on table using X-rays in a moving image with a radiologist there, you put some dye up via a catheter balloon into the pouch itself and inflate it, and you see whether there's any leak of that contrast out. But I hope I could convince you that compared to that kind of 2D operator-dependent image, we sort of developed a technique of using MRI, both moving images, but then in a post hoc three-dimensional slices to be able to look through in far more detail, and also sort of including the soft tissue detail in the pelvis that you don't see on X-ray, to try and really optimize the diagnosis of problems with the joint afterwards. And even within a small cohort of, I think maybe even just 16 people in this study, we still picked out one whereby the MRI was more sensitive to be able to improve the sort of patient journey and management of complications than the straight X-ray images were, the water-soluble contrast enema. So, and then we also did a study, and again, direct involvement of the Red Lion group here, looking at the sort of variation of patients with what we would classify as having normal pouches on questionnaires and investigations, sort of screening tests, and that it's very difficult to define what normal is. There are plenty of studies that have had a stab at this, but I suppose the summary being that when you are being managed in the longer term for your pouch problems or otherwise, or pouch health with time, there are certain centers that just do have a lot greater experience with this kind of work, and it's based on the sort of local expertise of people from the surgical, gastroenterology, radiological side of things as well, to be able to diagnose and manage pouch problems. So that's just, you can see sort of variation there in the shapes that pouches take over time. And we also included something that was even more kind of niche and difficult to define, which is pouch function. So for people that on the call or are listening later that have had an ilieoanal pouch, they'll understand that there is a certain difference in how you go to the toilet compared to when you have a rectum. And for some people, there's a certain amount of relearning, and in some people, it's a completely different coordination of the muscles when you're going to the toilet, and trying to define what the normal is in terms of pouch evacuation was something that we also undertook some research work into. Now, the patients that patients is wrong. These are not patients, these are participants. These are healthy participants who had a well-functioning pouch, were kind enough to be enrolled in a study whereby they opened their pouch in an MRI scanner. The problem being with that, the MRI scanner that we're using is not a sitting one, which are quite rare, but a lying down one. So there's a certain amount of it being a very different experience to going to the toilet normally. And then moving on to the sort of final part in the pouch journey, right? I undertook some research with Professor Clark, and mostly her series, along with Professor Phillips, Robin Phillips, of their series of people who had operations to remove the pouch. Now, for some people it's a bit much and a bit squeamish enough to have seen the original video that I showed you of forming a pouch, I decided that I didn't want to show this video on this presentation without people having consented to have wanted to watch something like that. But this, if you search this study, it's published under the colorectal disease channel on YouTube. So if anybody is interested in seeing the kind of surgery that's involved with potentially removing a pouch at a later date, then that's available. And basically what we demonstrated that was with increasing institutional volume, the outcomes became better, which doesn't sound like rocket science, but it is a sort of relatively rare procedure, apart from in certain centres that do have an expertise in doing it and are referred to do that work. And Professor Clark openly admits that maybe towards the later stages of her surgical career, she was taking out more pouches than she was putting in. The main problem that we identified with recovery from having an operation to remove the pouch is the wound down below where the anal sphincters are removed, and it can be that that is quite a prolonged course for some people. So about 15% or 1 in 6 people will still have a problem with that wound healing down below at about the year mark. So again, without being maybe a bit blunt about it, the counselling when speaking to somebody about having a pouch is not a kind of have a go conversation. It's not easy enough to say I will try to have a pouch, and if it doesn't go quite right, I'll just go back to having my stoma. It's not only more nuanced than that, but that whole phrase encompasses potentially years of having a pretty awful time of it and a potentially a quite poor quality of life, coming around to having that stoma again. So that's something that I'm highly cognizant of when talking to people about whether to decide to have a pouch or not. So a sort of summary of the things that I've presented there. Now, these are two of my counterparts who took over from my research work after I left, Amira Shamsidinova and Orestes Ajiriu. And I'm just about to show in a minute some of Orestes' work about sort of public opinion around surgery for ulcerative colitis. There is a lot of scrutiny on undertaking ilioanal pouch surgery in the UK and around the world, but particularly in the UK, and that is a good thing. Not only for people that have inflammatory bowel disease, we champion the IBD standards, but we also champion having criteria and metrics for centres, for hospitals that want to offer ilioanal pouch surgery. And this is mostly off the back of the fact that there used to be a pouch registry where data were recorded and submitted voluntarily by institutions performing pouch surgery about how patients are doing and potential complication rates in the follow-up. But that was probably not very well reported to and widely recorded. And in combination in 2017, when that registry closed down, there was some work looking at nationwide data again, which suggested that there was a real phenomenon of surgeons, but hospitals only performing very few ilioanal pouches, with the implication, obviously, that is associated with people or centres that don't have a lot of experience in offering this operation. And we know that, again, it's not just the surgery, it's the experience of the centre and the allied health professionals associated with it that are all involved in trying to make things go as well as possible. So the ACP GBI, the Association of Coloproctology of Great Britain and Ireland, drew up some guidelines about accreditation for centres and contributing data and recording data and making sure that for centres that want to offer ilioanal pouch surgery in the UK, that they have a certain number of resources available across all of the specialties associated to be able to offer the best possible outcome. And with that in mind, the numbers of ilioanal pouches performed in, again, these are English as data, has been declining over the last 10 to 15 years. Take these slightly with a pinch of salt, because these some of the coded data is not so specific, but using the same data codes, the operative recorded data codes for the same operations over time, it is reduced to maybe between 100 to 200 per year in the UK. And at the moment, there are a registered 23 different NHS trust centres that offer ileoanal pouch surgery. And I would be very interested for those who are here on the Q&A to offer their thoughts as to why that might be. So there's potentially, and this is speculative from my point of view, so this isn't based on research, but there's, has it made a difference that there's been a scrutiny and a push towards accreditation that means that some centres are no longer offering ileoanal pouch surgery? And along a similar line of argument to that English and Swedish study, where we noticed that it makes a difference where you have your colectomy as to then whether you're offered having a pouch afterwards. If there are more places that aren't undertaking pouch surgery, are there more people out there who aren't offered having an ileoanal pouch? And that's a really nuanced argument, because as you can understand, the counselling regarding having a pouch is complicated and tailored to different people, and it has to be appropriate. So that's a whole conversation in itself. The other part of the conversation is, what's the general tone amongst people out there who are thinking about having a pouch and what's the information they're receiving? It used to be that Facebook forums and internet forums were relevant, but of course, over the last 10 years as well, there's been an explosion in social media and the kind of influence that people take there regarding their healthcare. And this is some of Orestes' work recently to sort of canvass what's out there, and this is specifically on TikTok, but on social media, about the information that people are receiving from peers about what it means to have an ileostomy and what it means to have an ileoanal pouch. So that work is out there, published in poster format at the moment, and being presented at conferences, but in time will be available to read. But I'm speaking to the experts, so I'd be very keen to garner some of your opinion on that in the Q&A now. And if anybody would like to contact me, having watched this video at a later date, then via X, they're welcome to contact, or via guy.worley@nhs.net. And I can either sort of send them towards appropriate resources or refer on as required. So many, many thanks for inviting me to speak. I hope that was interesting and useful. And we'll very grateful to take any questions. Thanks very much.
Wow. Wow, that was absolutely fantastic. Thank you so much. Wow, there's so much in there. There's so much in there. And I was scribbling down the papers as you were going through it. A lot of them look like they're not published yet. So you're doing a great deal of research at the moment into various aspects. Or was that work that was done at St. Mark's?
That was all work that was done at St. Mark's, maybe apart from some of the last stuff. So I worked fairly closely with a medical counterpart called Jonathan Segal, and we were under this sort of supervision of Sue Clark, Omar Faiz, Janindra Warasabatani, Elsa Hart, amongst others. And that probably amounted to getting on for 30, maybe more, separate research publications during that time at St. Mark's. So you are right, an enormous amount of work came out of that period and continues to come out of the organisation and other.
Yeah, absolutely brilliant. We've got a few questions in the chat, not surprisingly. I'm going to hold off on mine, but so there's one that I've always been puzzled about. Linda raised it. I've always been puzzled. So when you anastomose, in people with active ulcerative colitis, you strip out when you create I think it's when you create the actual pouch join. You anastomose to the rectal cuff, but you strip off the lining of the rectal cuff so that there's no active disease, because the lining of the rectal cuff is diseased, or it can be diseased still. So you take the lining off, you anastomose to the rectal muscular cuff. Does the inflammation come back in the cuff? And is it the mesentery or the stuff that you stripped off? Does it grow back? And if so, is there a risk that it'll become diseased?
So there's two ways that you can form that joint, broadly speaking. One is hand sewn and one is stapled. And you actually only strip the mucosa, is the term for it, the innermost lining of the bowel, if you're doing a hand sewn anastomosis normally. Or if there's been some concern with cell changes towards cancer called dysplasia, or for those people that have polyposis and there's a polyp that lies very low near to the anus that needs to be removed.
Yeah.
But actually, that part of the rectum, despite it being affected by colitis and thus giving rise to what we call cuffitis, that small 2 centimeter sort of length of tissue afterwards.
Yeah.
It's also very important in terms of the continence mechanism. There's one analogy that goes within colorectal surgery. Imagine if you held in your hand a mixture that was solid, liquid, and gas, but tried to selectively let go of the gas, it would be almost impossible. Yet that's what your rectum and anus does on a daily basis, right? Again, I'm not being flippant, but the fact that that part of the body is so exquisitely sensitive and has reflexes within it that is able to work out what is what within the bowel and then go to the toilet or decide to defer and all those kind of things, that contributes to better function afterwards. So if that
Yeah.
bit is retained and not stripped away, that's a better thing. So that's part of the reason that we think that a stapled anastomosis is a better thing to do and not strip away.
Okay.
But yes, it can be affected by colitis, although for the majority of people, it tends to be quite quiet, but it can, that little bit that's left can give rise to what we call cuffitis and a bit of inflammation, but that's the logic for leaving it.
Okay, that's really good. Thank you very much indeed. So there's pros and cons.
Yeah.
Yeah, pros and cons. Okay, great. So you'd assess the health of that mucus, that lining, before you decided whether you're going to strip it away or not.
But the vast majority are now performed using staplers rather than stripping it away in hand sewn.
Yeah, yeah. Okay. One of our attendees tonight, Beryl, is considering the two operations just in terms of what you mentioned, IPAA versus IRA. They commented the rectum is found to be in good condition. Therefore, they would prefer the IRA, by the sounds of it, to the IPAA. Are there still some serious stoma reversal risks involved? I think you mentioned this at the end.
Yeah. So the advantages of an ileorectal anastomosis um, are that there's no need to go operating down in the pelvis, which is a narrow place. It's slightly more technically demanding, and there are nerves that run close to the rectum that affect bladder and sexual function, and so it avoids the need for a slightly more complex surgery. It also doesn't burn any bridges to potentially going on to have a pouch if the ileorectal anastomosis doesn't work out. And to be honest, stoma that you would then revert to if you wanted to just go back to a permanent stoma afterwards would probably be better as well. But the big payoff, the sort of the negative aspect, is that you retain quite a lot of the rectum that is still prone to potentially being affected by ulcerative colitis. And as such, you probably need to take regular twice daily or once daily anti-inflammatory suppositories to keep down that inflammation in the rectum. It's probably only appropriate in the first place at all if the rectum is very quiet and not too inflamed. And there remains the sort of potential consequence of ongoing inflammation in the rectum, which is a slightly higher cancer risk than general population when you have inflammatory bowel disease. And so it's necessary to have at least annual endoscopic investigations of the rectal stump to just check that everything is safe and well. And the failure rate is higher than a pouch. So the failure rate at 10 years is probably closer to sort of 20-30% rather than 10%, mostly in the case of urgency. So if there is persistent inflammation in the rectum, then you probably are tied to the toilet pretty regularly. Whereas for a pouch, you might empty your pouch fairly regularly, but not have the urgency, be able to defer and not need to rush to the toilet. That is the aim. Whereas it can be a bit of a different story if you've got a poorly functioning rectal anastomosis.
So that is a really critical, as best as you can have it investigated pre-surgery, that's a really critical step in terms of considering the IRA versus the IPAA.
exactly that.
Yeah. Very difficult to compare the two sets of data, isn't it? Because they're not the same populations, are they? One's still got a rectum, the other one hasn't. So in terms of outcomes, you're not absolutely comparing like with like, except to say that they've had a procedure. And whilst the
Exactly.
procedures differ, you're looking at outcomes per se.
And
Yeah.
there are plenty of people who are very skeptical about for exactly whom an
Yeah.
ileoanal anastomosis is relevant. Are these people who have had very, very mild or even no ulcerative colitis in the first place? I would possibly venture that there is a certain unfortunate group of people who have very bad colitis very early on after their diagnosis.
Right.
And there are, some poor souls, having been fit and well 20 something year olds, are in hospital and within a few weeks are facing the thought of having an operation in a permanent stoma. And there may have been relatively little inflammatory burden on those people's rectums. And so they are, if that disease was just short and sharp at the start, but then calms down quite a lot, well, there's probably not very much scarring there, and it's probably very pliable, and it might be for those people in whom it's an option. Young men or women of childbearing age, or people who are very concerned about sexual function afterwards, which is better quantified in scientific literature regarding men because of
Mm.
erectile dysfunction or retrograde ejaculation, and the idea of not having an operation that delves around pelvic nerves is quite appealing, and so there might be a payoff of sort of function risk versus benefit there. So it's highly nuanced, and it's about sitting in front of somebody that has got some awareness and experience of all of these things to guide people through it.
Absolutely fantastic. There's a question from the person whose questions you've just answered about access to you and your clinical expertise. Bear in mind they're from the Netherlands. So, do you get NHS referrals from overseas, or would it need a private referral?
Um, well, it would be best to start just by reaching out and contacting and working out whether, because always it is much better for people to have their care as close to home as possible.
Yeah, yeah,
But more than happy to be available to advise or to refer on to, there's an international network of people who who speak about these things and are interested and both clinically and academically. So there will be somebody nearby, I'm sure, to be able to identify and forward on to.
yeah. Okay, just a comment there on from Trish. They should be able to ask the NHS for a form, the NHS equivalent, for a form to be filled out. NHS England had a form that could be filled out to approve for passport abroad. So it looks like there might be a way, but if you drop a line to Guy, I'm sure possibly the best is to get referred to a really good person in the Netherlands.
Yeah.
But anyway, all right, that's great. A question here about, well, I'll read it out. After much abdominal surgery, adhesions can form, which make a total hysterectomy, if one becomes necessary, very difficult, if not impossible, particularly in elderly postmenopausal patients. Would it be easier and reduce the risk of adhesions and make a hysterectomy easier if one had a permanent stoma in the first place instead of an ileoanal pouch? Are patients counseled about this when deciding whether to have an ilioanal pouch? Quite a big question.
Yeah. So so adhesions are a generic problem with any abdominal surgery, as they sort of rightly suggest. And that I would hope is reducing with time after the advent of minimally invasive surgery, of laparoscopic surgery and robotic surgery. And but that starts with having your colectomy in the first place. That goes all the way back to having that index potential emergency operation. It's my standard and our standard here at the Royal London and at St Mark's to be able to undertake that laparoscopically rather than open. And then that has a knock-on effect as the potential options for then how the pouch is made and going forward. But safety is key, and sometimes it's necessary to just make a cut to be able to do things safely. Um, it's it's obviously this person's experience that they're now coming to consider further abdominal surgery. And yes, particularly if it's down in the pelvis, there's certain things around having a pouch that make things a little bit more complicated. potentially more complicated than having an ileostomy, but not specifically. Having at the time that I was working at St Mark's as a wide-reaching referral centre, there are unfortunately some people who have come to harm having had further surgery with a pouch that's not completely understood or recognised, and that's had quite significant knock-on, effects on their health and losing the pouch in some cases. It's, I think, maybe what the person who's asked the question is getting at is that it is very important to try and identify with any team that might be offering you further abdominal surgery to liaise with the people who have created the pouch or suitable colorectal surgical sort of point of opinion and advocate for that, and probably not be dismissed in saying, don't worry, that kind of thing wouldn't be a problem. I think it would be important just to be reassured that the people that are offering you surgery from maybe a different speciality completely understand and have liaised with their colorectal surgeons. I suppose that's probably the most generic, relevant answer I can give you in this format.
It's sometimes a bit difficult to anticipate for patients to anticipate problems that can be, oh well,
There
a
are infinite
different body
possibilities
system.
in terms
Yeah,
of, right.
yeah.
So
So that's a challenge with consenting generally, isn't it?
yeah, yeah.
Um, I've got a question here. This is a little bit complicated for me anyway. Is a non-functioning pouch that doesn't empty well? So I'm confused a little bit there. It's a non-functioning pouch that doesn't empty well.
Should we say
Likely
should we say a badly functioning pouch
a badly functioning pouch.
that
Yeah,
doesn't, maybe?
but
Yeah.
a connected, badly functioning pouch. Yeah.
Right.
Um, Likely to be caused by problems with the anastomosis. And if so, is converting to an estoma later on in old age, this is a separate question, I think, is converting to a stoma later on in old age a good idea?
Yeah. So there's one, I suppose, one point there about sort of working through what's causing bad pouch function, and there's another thing about the lifespan of pouches. So the first being that problems with pouch emptying could be caused by all manner of things. It might very well be that it's the anastomosis, the joint at the very lower end, but there can be narrowings elsewhere in the pouch. It can be trapping or become quite distended to the point whereby any kind of sort of coordinated pushing from the tummy doesn't result in things going the right direction. It could be to do with the muscles of the pelvic floor. It could be many and varied. And there's a whole load of sort of diagnostics to work through. Again, I can go into all of the detail, but roughly speaking, you would expect that you would have some imaging investigations, probably endoscopic investigations. And then in terms of when when a pouch isn't working and when to revert to an ileostomy, well, that is at any point that anybody chooses, and people have different thresholds for how fed up they are, and some people have what some people would consider on the milder end of dysfunction and want to revert to an ileostomy, and some people who is quite disheartening and challenging on our side are obviously having a really torrid time with a pouch that has given them problems because of complications, but are just so reticent at the idea of going back to an ileostomy that they will really soldier on with that poorly functioning pouch for many, many years. So the decision's down to the individual. And there is no absolute hard line advice as to age being a reason to revert back to an ileostomy, or even age being a hard line reason to consider a pouch or not in the first place. And the other thing to say is that I ran while I was at St Mark's the 40-year symposium of ileoanal pouch surgery in 2018, and we'll soon be coming along to the 50th anniversary of the 1978 publication of the pouch. And there are still some people around, and I spoke to Professor John Nichols the other week about something separate, and he told me just what a nice experience it is that some of the people who were the first people who he gave the pouch to are still in touch to say that they're doing very well. So there you go, 50 years, but nobody really knows longer than that because they haven't been around that long. And again, it's completely down to the individual.
Our treasurer now at the Red Lion Group is the son of patient number one.
There you go.
Yeah, patient number one,
Amazing.
who isn't unfortunately with us anymore, but that wasn't related to his pouch, may I say. Um, Let me ask you very quickly, and a little bit unfair, two questions, a little bit unfair. This is the guy. Were you surprised at the findings of the survey, the 2017 survey, that there's so many surgeons in the UK who literally done one pouch surgery?
Um, Probably not, and I think that was the reason that those two publications were made to make
Yeah,
that statement.
yeah. By the way, we can edit all this out.
That's
Don't worry
okay.
about that. Yeah,
I don't mind. It's all out there to read, you see. Um, but it's the other problem is that we don't have a robust system of reliably reporting the outcomes for those people. It's
yeah,
not to say that the people that had been the one of the five in a small volume unit hadn't done very well, but we know as a general rule of thumb that volume breeds expertise and that there's a certain learning curve on the technical surgical side to doing this kind of work properly. But it's a bit of a no-brainer that in places that will do more, there's going to be a higher level of experience. Um, but it's difficult to. We also don't have a straightforward way of obliging different centres to to undertake perhaps surgery or otherwise, or do it, or even allocate it.
yeah.
It
That's
doesn't
right.
come with quite the same sort of resource and high level organization that cancer services do.
Yeah,
And being an example whereby they have made a much stronger move towards centralization of certain types of procedures.
yeah, yeah.
I don't want to imply any kind of mistrust in the healthcare community,
No, no, no.
but it's having the conversation amongst professionals and amongst patient groups like yourselves, like the Kangaroo Club. I should give a shout out to my own very active Royal London IBD patient panel as well. There are several organisations whereby people can be directed towards reliable advice or referred on, and so yeah, that's the reason that we were interested in trying to work out what the influence of potentially less reliable source of information is and what the general conversation is out there about the attitudes towards stomas and pouch surgery. And I'd be interested to hear thoughts if you do have the time if anybody does want to drop in what the general kind of online feel is, or whether it's changing in regard to attitudes to having a pouch or not.
Yeah, that's something
Might be
we
a conversation for another
we
time.
The other question I was going to ask you, which is really unfair, but it's not you, it's not directed at you, but the survey came out in 2017. I think it was published 2008 early, and only now do we have the ACP GBI accreditation list, which came out earlier this year. Um, 8 years?
Yeah. So it was the movement towards getting that done was definitely started off by something like 2018, I believe. And at that point, there was the ACP body were writing letters to trust to identify it as being low volume.
Yeah.
So the movement towards scrutiny
So
has
it was happening. Yeah.
yeah, has been
Yeah.
that.
Mm.
Um, and even just the other month, in July at the ACP GBI meeting, the current members of the IBD subgroup of the ACP GBI are championing just that conversation happening for exactly the reasons that you've just mentioned, and
Right.
trying to corral people together
Mm.
to continue the momentum off the back of several years now of credentialing and scrutiny to try to improve the conversation and the optics of data submission, champion outcomes, consistent volume, and so I suppose be rest assured that those conversations are happening.
Yeah. Yeah.
And I have not worked at a
Good to
senior
know.
level within these organisations. It's a difficult balance of advice, but clinicians maintaining their autonomy,
Mm.
supporting places that have expertise, supporting, so and the other caveat is, are we talking about this on a background of the fact that less and less people maybe want to have a pouch. So the numbers of these operations happening is reducing as well. Again, it's not to be quoted because I don't think we have,
No,
you
no.
know, very specific, reliable data on that. But it's that's all part of the same conversation. So I've done a slightly politician style answer, but I haven't answered
No,
it.
you're going to go far, young man. You are going to
That's
go
the
very far.
landscape. That's the
Yeah. No, it's interesting that the amount of biologics being prescribed is going up and up, and there's not anywhere near a proportionate decrease in the number of pouches being done to account for that. So there must be other factors there, which is interesting. Um, Let me ask you a totally different question. It's cropped up in the questions here, but actually, I'll save that for a minute. I'll say that for a minute. And just how many people have a pouch in the UK?
yeah.
I mean,
So
I know we don't know exactly, but what's your estimate?
I wonder, roughly speaking, if it's around the 10,000 mark.
Yeah.
I wonder. And I'm sorry, I'm not prepped for that question. And I remember
Oh, you don't have to
doing that sort
apologize.
of
Mm.
rough calculation back when I was a research fellow, and I think it was around that kind of number.
Mm.
I'm sure there's people around the world who are watching this back, pulling their hair out that I'm way off. But that's for the UK, I think.
I think you're ballpark, a magnitude of 10 either way. No, I think we've heard 6, 8, 7, 9,
Right.
10, 12.
Good.
So
So I'm
you're,
not too
you're around
far
about
off.
this, around about approximately. But it's a rare condition, isn't it? It's a
Yeah.
rare, in medical terms, it's rare. Yeah, and yet it's at the Royal London. You're managing to um, get the funding and the facilities together to introduce pouch surgery back at the Royal London, which
Yeah.
is a real credit to you.
Yeah. So the funding's not a problem, and the resource already exists. It's an absolutely stellar gastroenterology unit with wide allied specialty support as well.
Mm,
And for off the back of the pandemic and off the back of the sort of the leads for IBD surgery changing over, it's been a sort of appropriately put the brakes on in-house because of the scrutiny and wanting to do it right.
yeah,
And so part of the remit having started there is to set that up again for the local population. You know, there are around 6,000 people in northeast London on our books with inflammatory bowel disease who we care for. So there's a real
mm,
reason to be able to offer
yeah,
this service for people in house. So
yeah,
it's about, and we've got plenty of people on the books now who would like to have their surgery and intend that we're going to then be starting in a way that we have a certain amount of consistency for
yeah.
people.
Brilliant. Let me go back to that general question for attendees about this is long-term pouch health. How do we keep our pouches healthy? Any tips from the top and to reduce the risk that we might one day have a problematic pouch?
Yeah. Um, There's probably only three things that I can think of. And again, there will be clinicians around the world who might have more specifics to offer on this. But I suppose the first thing would be engaging with your team at the first sign that there might be anything wrong. Because as with the majority of things bowel related, IBD related or otherwise, the quicker that you can be off the mark in terms of capturing a problem and dealing with it, the better in the long term. If, for example, in the case of inflammation and pouchitis or a fistula or an abscess there, the longer that's left to grumble and cause scarring and a lack of the pouch being healthy and soft and functioning, then the better. Going to the toilet when you need to, not holding on to things and putting any extra stress on the pouch or any extra stress on evacuating. It's probably something. And then the last thing I'd say was that it might be that there's nothing you can do, and that unfortunately that you're dealing with disease processes that, again, particularly in the context of colitis, inflammatory bowel disease, or the spectrum of inflammatory bowel disease that then affects the pouch afterwards. It's a lifelong relapsing, remitting condition, and we don't know necessarily the triggers that set things off or not. So it sounds slightly nihilistic, but it might.
Looking on the bright side there.
Looking on the bright side, there are in terms of the diet, it's outside my expertise. diet, microbiome, some really interesting work in that the ileoanal pouch is a microcosm of gut health and the microbiome and the behavior of inflammatory bowel disease. It's in creating this reservoir and attaching it down to the anus, it remodels itself to become more like the colonic mucosa that it replaced. Who knows why it does that? We know that there is a change in the gut flora and the microbiome compared to what it would have been if it was just small bowel in continuity before the colon. So the other reason I'm slightly cagey is there's a whole load of things that we don't know and don't understand, and most
Yeah.
of that is wrapped up in probably microbiomic work and the way that inflammatory bowel disease behaves.
Mm.
As to, you know,
Yeah,
I wouldn't have
brilliant.
any anxieties about what to do to keep it healthy. It's just, it's something to engage with your team if it's not right for you, and otherwise enjoy being healthy and well and not having to see us.
Mhm. Okay, one last question from me. I know I'm pushing it a bit, but the survey the survey suggested two risk factors when you're considering the pouch surgery, which what we quote to people when they write in and say, what should I be looking for? What should I ask about? One is Crohn's, not ulcerative colitis. So one thing we say is try and get as definitive an answer from your clinical team about whether you've got UC or Crohn's. That's the first one. And the second is the experience of the surgeon. So to ask questions like how many pouch surgeries have you led? What have been the outcomes? Who would you go to if you needed this sort of surgery? This is a bit unfair. Are those two risk factors still valid? And are there any others that we should be counselling people who come to us for advice?
Um, no, they're both really important. I suppose the first one is is sort of very much the remit of whichever team are guiding you about having pouch surgery in the first place, because there's a certain amount of steps that people should go to try and work out that there is no evidence of it being Crohn's disease. But
Yeah.
you're absolutely right in that if you need to advocate for yourself in that regard, then there should be a combination of imaging of the bowel, either an MRI scan or a capsule endoscopy to look through the small bowel and double check, probably using a fecal calprotectin marker of inflammation from the bowel from the ileostomy if you have one, and then also revisiting the histology, revisiting what the colon looks like under a microscope from somebody who's got expertise to double and triple check. And then I would probably broaden the net for the second question into the whole unit rather than just the surgeon, because
Oh,
you're of
yeah.
course
Mm.
interested in them doing the job right in the first place, but you also want to know if this is, if this is sales, if you're buying, you want to know what's your what's your aftermarket support, what's going to be your user experience going forward. That's what this is. Some
Mm.
people are cynical about ileoanal pouches being essentially cosmetic surgery. This is a quality of life procedure. That's why it's different to the majority of things that we do, which is chopping out the badness. That's the essence of what we do in the majority of surgery, specifically colorectal as well. There are
Mm.
very few operations that we augment or we create. And this is why these sort of procedures stand alone as being something a little bit different with their own expertise. But it's a lifestyle procedure, and it's about reaching a lifestyle improvement. Was it
Brilliant.
two pence to end on, wasn't it?
Absolutely brilliant. Gary made a point in the comments that he feels that lifestyle attitudes have changed to having a stoma, and that's a big factor towards people choosing to have a stoma rather than a pouch. I don't know if you want to elaborate, Gary. Gary's doing something else. Look,
I'm
horrified
actually,
of
well, I'm biased because I recently, after nearly 40 years with a pouch, I've gone back to stoma, but I won't bore you with all the details of that. But I think generally, there's a lot more talk on media, TV, and radio from people with stomas talking about, there's like, what's her name, the Bowel Warrior or something, and all these people talking about it, and lots of people posting pictures of themselves on beaches with stomas. So maybe in a way, it's there's a different view towards it. In my case, of course, I would always have chosen to have stayed with the pouch when it was behaving very well. But when you get to a point, as you pointed out, if your pouch is not behaving very well, then there comes a time when you have to accept you're going to be better off with a stoma, which is the way I'm feeling at the moment. So, but I'm still here fighting the cause for pouches. Don't worry.
Yeah, good man, great.
Yeah.
And Tricia comments about the improving products as well for stoma care, but
Yeah.
you know, this you can't play rugby with a stoma.
Well, I don't play rugby, but it
Oh,
doesn't
no,
stop me.
I'll
Doesn't
leave.
stop me playing golf. In fact, my golf has improved. Maybe that's.
Yeah, we've only got your word for that, Gary. And frankly, you know, no, listen, I'm called quits now. I know I hogged some of the questions there, so I'm sorry if I inhibited anyone asking questions, but there were some great questions. It's getting on. He's still at work, ladies and gentlemen. So let's give him the chance to get home and have a bit of beans on toast or whatever. Guy, can I thank you on behalf of everybody here who's had the pleasure of listening to your talk and had the chance to ask you questions, but also the wider pouch and potential pouch community who will be able to download this webinar in future and benefit from the pearls of wisdom that you've shared with us tonight. It is an absolute pleasure for me and any others to have the opportunity to see you again. You've always been a great servant of Red Lion Group. We loved you when you came to the information days that we used to have, and it's absolutely fantastic to see that you're absolutely uh, doing great in your career and doing great things at the Royal London Hospital. And we wish you all the very best with that. And I'm looking forward to the time when we can get you back again, because I'm sure that the amount you're churning out, there'll be lots more to talk about next year and the year after. But for now, on behalf of everybody, thank you so much and keep up the great work.
It's really very kind of you. Thank you. Thanks for the privilege
Thank
of
you,
being
Guy. Thank you, Guy.